Wait for collecting them.
This is 3, I think we've got the polygon.
Yeah, I'll wait for that. It's okay, we're just waiting for some members of the public.
Listen to that rain.
Afternoon, everybody, and welcome to the public board in the ICB for BNSSG. Welcome. You're not on trial there. It's a bit like that, isn't it?
This committee was in June, and at the time we heard of all the initiatives being put in place and knew that it would be quite a challenge to get there. But we are probably 4 weeks away from the end of Q2, and we stated that there was a commitment to achieve 15%. We're currently still at around about 21% from my last set of numbers I've looked at. Could you talk a little bit more about this 1.3 million? Was that in the original plan? Is it something additional? I don't recognise that 1.3 million, and trying to understand a bit more about what that is. And
It's disappointing you don't recognise it because it was part of the plan that came through performance, outcome and quality. That we always knew we would have to spend more money. So if that hasn't come across, apologies. It should have come across, so I'm sorry about that. Yeah, okay. So because actually for us to be able to deliver all the actions we were talking about, some of them had a cost, and this was one that had a cost of £1.4 million. So if that wasn't extra above what we were spending, what our approach was to look at the schemes we had already put on the ground, to look for slippage in those schemes, to be able to get to the 1.4 million, to be able to deliver the additional P2 and P3 capacity. So, and we have not yet been able to do that. So if that was not clear, I do apologise, because it should have been clear this was dependent on us being able to secure the 1.4 million pounds. We have, so all the other schemes, all the other programmes that came to the committee are in train and are working. This was additional to clear the backlog, and we've not secured the resources for
so
that.
when, as a board and as a committee, when would we expect to see some improvement? So in a month's time, for example, would we be confident that we'd be reaching that 15%?
No, sorry, if I just, 15% I don't believe is deliverable without hitting these additional capacity. I think that's important we have that on record, Chair. Without this additional capacity, which was in the plan, I don't believe we can hit the 15%. And I don't think I would suspect our systems partners might say the same. Okay, so I think we can get lower, but this capacity is needed as per the modelling to get us to 15%. But I would ask Dave to come in.
Two things. So, Ellen, when we came to outcomes, quality and performance in June, we talked through all of the actions that were taking place. We talked about the modelling work that was taking place to be clear on what our required capacity to deliver 15% is. That work concluded over the summer, which then has led to, there is a backlog which we need to resource, which is the 1.4 million. So it wasn't in, we weren't at that point at the Outcomes Quality and Performance Committee. We've got to that place of really understanding the required capacity to deliver 15% over the course of the summer. So that was the timing piece. Two things though, as Shane said, we have, well, three things. We have identified some slippage which can enable us to move on with some of that required capacity. I've got a conversation with the Chief Operating Officers next week to prioritise how we might, how we then bring that online to start eating into that backlog and what's the right way of addressing that. Secondly, we do continue to look at the benefits being realised from all the other initiatives that we have in the system, where it might be appropriate to realign some of that resource to support this capacity. So that's the second action that's taking place. And thirdly, all of the other improvement activity that was associated to all the different pathways is ongoing as well, which is all part of delivering the 15% as well, is all in action. Sarone have been doing an amazing job at increasing their pathway 1, which is discharging patients to home. That has been without additional resource, and that is coming online really strongly. But to deliver our system ambition does require this bump in capacity, and we continue to prioritise what we found, continue to look for further slippage and further investment, and continue to drive the improvement initiatives we got through emission avoidance schemes and the other pathway developments.
So what will you be looking for? By the time we'll meet in another month's time, what numbers would we be hopefully looking to see? If we can't achieve the 15%, what do you think you'll be looking at?
I don't want to publicly give a figure here. What I would want to see, Ellen, is that we are. You've said we're about 20% today as a system. We are. I'd want to see that. I'd want to see a step change towards that 15% by the time we meet, because there will be some of that capacity we will have brought online, which will have started eating into that.
Thanks, Alan. And I think useful that you're keeping on top of that at the committee. Mary, is on this point, or was it another point? No, because I got Hugh and I got Alison. Right, no, Alison first, then Hugh, then Maria.
It's a variation on the theme. Jane, thank you for your report. I always enjoy the three things that are in your head that are important about work that come to us. The number 2 and number 3 are linked for me, and it is a variation on what Ellen's saying. So the title of number 2 is around sustainable system performance standards. And I don't want to simplify what is a really complicated, layered system approach. But if 1.4 million out, and I'm looking at item 3 as well, we're in a deficit, but if 1.4 million in the overall pot of money we have in the system delivers us sustainable system performance standards, that's a big thing, and it's a lot of money. But in the overall scheme of things, if that is going to be the thing that gives us sustain, or is going to give us 15% for this winter, but at the moment I'm going by the heading, which is sustainable standards. So for us to sustainably achieve our standards, if that 1.4 on top of all the other brilliant work and where we're making improvements is the thing, then I really do encourage you, Dave, saying, looking at where you're currently investing, disinvest if you don't. But I know it's a big sum of money, but in the scheme of things, it's just there. So am I right in thinking it's about sustainable standards? Because if it is, we should be really thinking about it.
And if I can, so think about the model, something is about what you might call stock and flow, okay? So flow is the normal business that travels, and then we have backlog. The 1.4 is about trying to deal with that backlog, 1.4 million, on top of all the other stuff we've introduced about flow. So you are correct, that 1.4 is about buying capacity to remove the backlog, which begins to remove the level of bed occupancy, which begins to remove some of the barriers and drive flow. So you are correct, the 1.4 is a really important piece. But that's why 2 and 3 are linked. Because actually the 1.4 on top of a position, we're already £13 million the wrong way. If it was 1.4 in a normal year, you might go okay. But actually we've invested the base of 50 million into this in the last, and it's 1.4 on top of that with a deficit of 13 million. So I agree, the 1.4 doesn't seem that big. It's massive in the situation we're in at the moment, but it's about clearing backlog, and it's really important. So Dave and Sarah and all the directors of finance are really, really working on this, because it could be one of the keys that really unlocks it. But 1.4 on top of 13 million already the wrong way is a real struggle.
I guess the concern is the amount of time it might take to identify things to disinvest in or swap money around from to have the impact before the winter, which is what we want. So I guess there could be a timing pressure.
Which is why as I just said, I've got conversations next week around prioritising the allocation of what we have well ahead of winter.
Okay.
Okay, thank you both. Comprehensive update. I think really important we keep asking the questions, though, and I think that point about is the dial moving is a really good one. So Hugh and then Maria.
And Sarah as well.
I think you did what I'm going to say. From a Director of Adult Social Care perspective, whilst I do appreciate the pragmatic reality and the need to find solutions to system flow issues now, I question whether bed-based solutions are going to be transformational or inspire system change. We would always look to favour domiciliary solutions, reablement-orientated solutions, and to solutions that enable people to remain at home and avoid hospital admission in the first place, so admission avoidance type solutions. Whilst we will strive to manage additional beds in the system, they will create flow issues for us. It does push it down the pipe. So at the end of the day, I just want to highlight that and raise that point, but we obviously still want to remain active partners and helping to solve this system issue.
Okay, thanks, Hugh, and I think it's important to record that. So, Maria?
I think it's not an either-or situation at the moment. We need both. So we need the backlog done whilst we're doing the transformation work, and would agree that's where we want to be, but it isn't where we are at the moment. No criteria to reside is a very expensive way to deliver care, and you're not actually delivering care, you're putting people in harm's way. They are ready to go, and they're in an environment where they can fall, pick up infections, all sorts of things. So actually the two are very linked. Alison, if you're not delivering care in the right environment, it's costing the system far more money than it needs to. I'm grateful for people's focus on the numbers, and would also urge that if we are going to procure before Christmas, we do need to get our house in order, and it would seem a sensible investment given the scale of the problem. And as we know, this all tracks back also to delivering a 4-hour standard. That is part of the process. We need a particular no criteria to reside, a particular occupancy to enable us to deliver the standard that we also signed up to as a board.
Okay, thanks, Maria. Anne?
Hugh, I think my comment would be that if we can get someone home, that has to be the first thing we look at. For some people, home might not be possible for a variety of reasons, including their home accommodation. And we have to remember that there are some people who live in conditions that we would not feel able to support them in whilst they need additional care and whilst we look at their longer term needs. So I would hope that in the vast majority of instances we will be looking at nursing beds if additional beds are necessary, because we really should be able to find solutions for others. I would also say that when we are looking at bedded capacity, it is about the right beds in the right care homes with the right ethos behind the way they operate and the staff they employ, so that we are maximising the opportunity of recovery for those patients who then become temporary residents in that care home. So I think it isn't about buying in a block necessarily. It is about assuring ourselves that we are purchasing the right bed in the right place. Thank you.
Thanks, Anne. Jane, you want to come back in on?
Sarah? Come in.
It was just really to reinforce the point about the work that's going on between the COOs and the DOFs across the system, really to understand. So as well as that meeting next week, there is also work going on to really understand, particularly digging into what's actually happening in some of those urgent and emergency schemes now, to understand what more can be freed up. So Alison, it was just to give you that assurance in terms of how quickly we might be able to do that. We have been to the DOFs, got their commitment, so really trying to make sure that we are getting that done before next Friday.
Thanks, Sarah. Deb?
It's more of an ongoing thing, but one of the things that we did in Penn was to set up a joint data leads group that includes people from right across the system. And it just strikes me that looking at impacts of this investment, so not changing anything, but actually looking at the impacts of this investment in terms of the points that you've made, Jane, about this is about a supply of stock and flow. It's a supply chain. And what we always do is we focus on the demand, but we never really focus on our capacity to meet that demand right across the system, which one of the things that Care Traffic Control gives us is much better insight into that. But we still need to do a piece of work where we start to think about how did this investment actually change those nodes in the system, and the capacity and demand match or mismatch, and also the time frame, because if you miss a community nurse appointment, you don't get it back. It's not a linear process. If the time has passed and we didn't utilise it, it's gone. So I've got a meeting with that PEM-orientated UEC data group tomorrow, actually. So it may be a useful thing to feed that through and to say what we want to do is to try and track the impact together collectively as a group of data leaders to be able to then feed back and give you some of that support back in a way that we haven't actually done before. So it's really an offer about addressing some of the points that our non-execs have flagged. But if we get all of your support to be able to do that, that would be a very useful thing that that group could contribute to.
Okay, so we need to think about how we capture that, Dave. Shane, is there anything else you want to come back in on?
That point.
Okay. Thanks by way of update. That generated quite some conversation, as you would expect it to, so thank you. The next item on the agenda is our annual assessment letter from NHSE. Shane.
Yeah, thank you, Chair. So I'm not going to get into any detail on this. This letter is an annual assessment letter that that NHS produce. They consult with some system partners. They look at our documentation, etc., and then give us a view. The system is, it's based on how we met our objectives, how we're working, etc. The letter is in there for people to look at. I've created a short summary at the front, which is also to look at. But in summary, Chair, and Mark is one of the authors of the letter, so in summary, we are doing the things we need to do and running as a system and an organisation the way we need to run. There are opportunities for improvement as well, so we're not perfect, there are opportunities for improvement, but the letter is there, and if there's anything that people want to ask of me or the letter, I'm more than happy to do so.
Thanks, Shane. Anything you want to add, Mark?
No, nothing at all, other than just a tiny bit of context. The letter is a formal statutory requirement of NHS England to produce once a year. It's related to, but very different from the in-year oversight framework which we run, which puts you into a certain segment of either support or asking you to share with others good practice. So they're related, but very different processes. So just to put that in context.
Any questions or comments? I mean, there was some stuff in there that we looked at. How do we develop? We have brought some of that back to the board in separate items and to the ICP as well. But any comments or questions from anybody? No? Great. Thank you very much. On to the next item then, Deb.
So this item is for board assurance, and in response to the recent global IT outages that people will have, I'm sure, come across. So on the 19th of July, the CrowdStrike incident affected globally healthcare, banking and a lot of retail, but also airlines. Its estimated cost is about $5.5 billion and growing internationally. And of course, the impact varied across the NHS. But for us in BNSSG, it was really quite significant because it impacted our EMIS system. And it meant that for general practice, the ability to access EMIS, to be able to see appointments, to be able to see information, it was a very significant impact. So what you've got in your pack, which is not, it does say decision, it should say assurance, is just to let the board know that there is diligence and there is a robust business continuity plan in the background. What we've done is updated our business continuity plan in light of the lessons learnt. This isn't something that we could have avoided, but it was a good test of our business continuity in terms of its planning and in terms of execution, and we learnt some things. So I think the positives is that Dave is having exec responsibility for EPRR, and myself from a digital perspective, I think there was a strong partnership arrangement that worked incredibly well. The input from OneCare was exemplary, as was the input from the LMC, that I think is really important to flag. And all system partners, even though our acutes and our local authorities weren't actually impacted, it was really important that everybody came together just to make sure that we could understand. We learnt a lot about pharmacy and the importance of pharmacy systems that are not within our purview, some really important connection points. And all of that has been updated in the business continuity plan that you've got in the pack. Because we're in open, there are some things that have been removed from it, people's contact details, etc. Those are there in the real version. I think the lessons that we learnt was that our communications needed to be better. There were system opportunities for GPs to be able to access things like Connecting Care, that because people didn't have their logons and wasn't available quickly, that wasn't implemented as fast as it could have been. So I think we did quite a lot of learning that's all been updated in the communications packs. And I think, one of the things that is really important that we as a board own is that this is part of our civil contingencies responsibilities. These are statutory responsibilities. So I just wanted to make sure that, given there was also a secondary impact, which didn't affect us, but if any patient tried to access NHS App, that was a week later. The spine went down, there was a whole raft of things that were impacted by a separate event, and only last week we had a cyber incident that didn't have any implications, but a partner in our system experienced a cyber incident. So these things are coming at us thick and fast, and it's just about making sure that as a board we're comfortable and content that we've got a robust process, and that as a board we understand those responsibilities, and we're making sure that we are undertaking the right level of assurance to make sure that we minimise the service disruptions for our population, because no longer is it about digital, it's actually about the ability to deliver our services in 2024. So, and then just to head off any questions that colleagues might have about cyber risks, yes, they are linked. There is a cyber strategy that will be coming to us in the new year. For obvious reasons, our cyber strategy will not be an open. That is understandable. We wouldn't be saying, here's some unlocked drawers and some things that we need to do. But that will be coming through we've got a system-wide cyber group, and that will be coming to us in the new year.
Thanks, Deb. Questions or comments? So just one question in the preparation and sharing. Presumably this runs through the civil contingencies group. Is there a system beyond health and social care?
It's linked into the EPRR system for us.
Yeah.
So that's how this links in through Dave's team.
It's got the Local Health Resilience Forum, Jeff, which I co-chair with Matt Lenny, which then links into an even broader whole system group, which is chaired by Constabulary.
Okay, that's because this would
so
bring
all into it.
This would bring bread and butter for me, but to make sure that we are sharing what others are learning and doing, and their capability and that they've got in the system.
We'll get that through the. I can't remember. It's the Avon Executive Group or something like that. Really. I can't remember. Exactly that, Jeff.
Okay.
Best practice sharing between partners.
Yeah. All right. Thanks, Dave. Any other comments or questions, Jaya?
Ricky, we talked about this report about the systems and sort of how we make sure we can have offline, and is that going to be built through everything based on the learnings that we've got? I know it will be, but I just wanted to ask.
It's also about where you've got one system that goes down. So what you'll see in the paper is that we're developing these handbooks for every individual system, so that on the 19th of July I happened to be around and picked the incident up. Dave happened to be around. But where there are situations that nobody from a digital perspective is around, we need to make sure that we're really clear. And then also it's what is the business continuity plan? Because what we had for this is that EMIS wasn't accessible, but Connecting Care could have been through a different link. So sometimes we've got business continuity between our digital systems, as well as here's what you do when you have to go back to paper.
Okay, thanks. Just on the LRF and the Local Resilience Forum, who represents health on there? Is there more than one partner? Yourself, Dave.
So on the Local Resilience Forum, it's all of the health partners and local authority partners on our BNSSG group. On the Avon Constabulary Chair group, I represent health.
Okay. Yeah, brilliant. Any other questions or comments from anyone on that item? No? Great. Okay, thank you very much. Annual report on the Green Plan delivery then, Sarah.
Thanks, Jeff. Can I just start by introducing Sam Willits, who's the Head of Sustainability for the ICS. He works out of MBT, but certainly working on behalf of the whole system. So I'm really pleased to, he'll answer all the tricky questions. So I'll give an introduction to the paper, but then definitely if there's tricky questions, they'll be with Sam. So I am really pleased to bring this to the board and really to demonstrate the work that's been going on. I think you'll see in the report there's still a lot to do, and some of the numbers are scary, but almost you've got to understand that before you can really make the progress that you need to. So, and the bit I feel really positive about is I think there is some building momentum, and I think you'll see sort of throughout the report and some of the examples, some of this is about building a movement and really getting that energy behind this. You can see on, if you're looking on Diligent, it's on page 77. It's figure 3 in the report on page 6. But I think that sort of diagram really helps to show the progress that's being made. So, but it still shows we've still got a long way to go. So if you look at our current sort of carbon usage in the way that it's measured currently, we've got about 400,000 tonnes of carbon, and you can see that we now have plans identified, not necessarily with a funding source to them, but at least knowing what does need to be done to reduce that by 257,000 tonnes. And at least, you know, having that identified means we can carry on working. And some of what we're trying to do is working nationally to identify, is there a way that we can do this without needing Citadel, the capital expenditure limit? Because, you know, it needs to be, there are third-party people that would be willing to do this, and the energy savings could provide the payback for that. But we need to work through a methodology to do that. What we have done is we have prioritised a small element of system capital, 3 million, which is enabling us to leverage in other funding streams, which has been successful in starting to make that transition. But it does also show us where we've still got further to go. And some of this is going to be about influencing some of the national commercial strategies, because some of this is about suppliers that are providing services to the NHS or products where they may not be under the same, you know, if they're international, for example, they're not necessarily working to the same timeframes as us. So there's some of those issues that we need to keep working nationally. And also, so that's both from a procurement perspective and also from a medicines perspective. One of the things that we've identified is that when we're then looking at how we're actually doing against this, we don't have brilliant ways of capturing some of the monitoring at the moment, so particularly on the procurement side of things, and there is a lot of work, and we had a really good presentation at the last Green Plan Steering Group from Bristol and Western Purchasing Consortium on the work that they're doing. But the current measure that we're using is just our spend on consumables, which obviously when there's been a high period of inflation, it looks like then we've massively increased our carbon, which obviously isn't true. It's just that the price we're paying is higher. So they are working through, and you'll see in the report the work that they're doing, but that is further work to do. So I won't go into huge detail in terms of all of the different work streams. What we do have is a rolling programme of those work streams coming and feeding back to the Green Plan Steering Group. Sam's work, what we're trying to do is embed that in everything we're doing. So we started last year sort of through the planning process, asking people to identify, because the last sort of work stream on this is really all about, and if you think about the work we're all doing together on Healthier Together 2040, because the most impactful thing we can do is keep people well in their communities and not needing the high carbon hospital services. So it really does link to that broader strategy work, and so keeping this at the heart and getting people really thinking about this when they're planning services, thinking about the travel and transport and all of those things as well, really important to take into account. I have to say, you know, Sam's putting a huge amount of energy into this, and we are getting that momentum. I think probably, you know, we are one of the systems that are probably further ahead than others. So, but there's still a huge amount more for us to do in this space. But just want to say a big thank you to all the energy that's gone into it so far. But happy to take any questions. Yeah, exactly.
Alison.
I really enjoy reading this. And I was really struck by the Green Operating Day in neurosurgery because the reductions of waste or opening of consumables in one day, the one that I was also taken to was staff reported an increase in productivity, more efficient workflow, improved communication, all of that stuff. So I guess the question is, how do we go from one green operating day to green operating, and what do we need to do to help people to do that? Because these improvements around in a highly stressful environment about improved team working as well as the green is really good stuff. So is our strategy to make it not to have one day but to make all days green days, and when would that be? Sorry if that's...
No, that's absolutely it's key of how we can expand that really big successful piece of work. It's already, I believe next week, the neurosurgery team that undertook that are going to UHSI with the pediatric team to look at how they can do it there. So it is being expanded and we're capturing all the learning from that event to really see how we can spread it much more widely, because it's such a clear example of where the staff have come up with all the ideas and it could easily be implemented much more widely. So really
And we have a lot of theatres. I mean, it would be, it would be really nice to have a plan for all theatres in our patch by a certain date. But I understand it's adult neurosurgery to paediatric neurosurgery and then like that. But I would encourage whatever you do to broaden that out. Sounds really good.
That's a point well made, I think. Chair?
Thank you. Really, really excited about this happening and pushing it forward. Good that you're talking to City Leap. Is there any scope for any of our buildings to join some kind of heat network? I know there's stuff going on in the city, and has that conversation happened? And also, there must be an impact on buildings that are PFIs, so there's only so much you can do, and I'm guessing that it would be good to get a feel for what proportion of those buildings are in that bracket. Hoping that there's some kind of battery system thing going on as well, so that we can buy cheaper electricity, so there's a win-win on the cost. And finally, it would be great if we could link what we're doing on the green plan with reducing workforce inequalities. Certainly if we can deal with the travel aspect and the time in travel, those sorts of things, it would be great to link them in terms of the metrics.
Okay. Sam, do you want to?
Yeah, so on the heat network side, and working with City Leap, absolutely, we're very closely working on the link. For the heat networks in Bristol, it's a key, the hospitals are a key anchor load, but they're very keen to develop and look at networks around the hospitals to make the system viable for the whole city, and potentially linking to a waste heat from Avonmouth, which could also be a route to getting a cheaper electricity supply linking to the wind turbines. So there's some really big opportunities, and in terms of that link to the investment, it's probably one of the clearest routes to our third-party funding is a long-term heat contract that would enable us to sign up. If we sign up to a 20-year deal, it would allow that infrastructure to get put in, which would reduce our volume.
Okay, thanks. John?
Kind of anticipated my next question, but just wanted to hear a little bit more about the third party, the funding, the off-balance sheet, kind of where that's at, likelihood and timescales and so on.
Well, it's getting that solution which is acceptable to the Office of National Statistics. I think in the end when it makes the decision whether it's an on-balance or off-balance sheet decision, and it's going to require engagement nationally, Treasury, and to be able to find that acceptable solution. But I think where we're a heat supply really isn't like a PFI, and I think that's where we can make the case, building up some models of what we want to do, the money that's required, and it's just this blockage of finding the solution. But it will require us to lobby and really push for it.
I look forward with dread to the conversation.
Any other comments or observations? For me, has the arrival of the Green Leader in Bristol made any difference? And has she taken an interest in what we're doing?
I think it's definitely increased the aspiration and actually the opportunity to lobby. We also got the Chief Secretary of the Treasury and an Energy Minister.
Yeah.
So, in terms of actually coming up with that solution, I think we might have a useful political will in the area.
Should we invite them?
Well, I think it's definitely one for Shane to be agendering with the MPs when we see them, to talk about progress that's being made our green plan, so that we should be proactive around that rather than reactive, because we're going to get the questions asked. So it'd be helpful to do that, wouldn't it?
Yeah, more than happy.
And the other one I've got is the agenda says it's for update, but the paper says we're looking to approve the report. Are we looking for approval or
It's
update?
really that we're not given a formal format, but we feel that we do need to report annually on this. So we're really asking that you're comfortable that this is our annual report. I think it is a really good demonstration of all of the work that's going on across the system. So that's why I felt it should.
So the work is what the work is.
Yeah, exactly.
But it should be for approval, shouldn't
Yeah.
it? It should be whether we are happy with that or whether we should be taking a different direction around it.
Yeah.
So I think it is for approval, but the work is the work.
Yeah.
It's not going to change, is it?
No.
If we decide not to approve it, that's what's been done. So any other comments or questions?
Just one very quickly, Chair, if I can. So, fantastic report. You are one of the leading ICBs, certainly in the South West. I happen to hold the green team as well as part of my portfolio. I'm very keen to progress this with you as well. If there's anything that we can do to help in the discussions with Treasury, we're also doing things around, not directly related to this, key worker accommodation, where we're testing new financial models, aren't we? So if we can help in any way, please let us know. And also, are you willing to perhaps share through Shane and the other ICB chief exec some of this work? Because I think there's a lot of learning in here, which will be great to adopt across
it's
the
in the public
South West.
forum anyway, so of course you would, Mark. There's clearly opportunity for us here, isn't there, to be proactive in what we're doing.
Thanks.
Hugh.
I was just going to say, I mean, anything I can do to enable linkage with our political leadership, obviously very happy to do so.
Yeah,
I know they'd be very keen to.
Yeah, good.
And we do have good engagement, don't we? We've had presentations and things like that coming through from other partners. So.
Okay, thanks, Sarah. Thanks for your time. I think that detail's really important, and this is a growing and a really important area for us. This is about the future of the planet, isn't it? So why wouldn't it be front and centre? Any other points before we move on? Okay, Dave, health and care improvement groups. You've circulated the paper with an update on what we're doing. But over to you.
So, Jeff, I'm not looking for approval of anything here. This is just an update for the board, just to give a very high-level overview of our ongoing development and progress of the health and care improvement groups. I did just want to say, not in the report, but I did want to note a really helpful conversation we had at a System Executive Away Day back in May, which has really helped to refine the focus of the health and care improvement groups towards service improvement as opposed to performance management, and that's been a really helpful clarification for the groups as they continue to evolve. We've also worked to simplify and focus the highlight reporting and escalation into the System Executive Group when you've got the first version of our new escalation report there. So we've really kind of worked to finesse our reporting and escalation into System Executive. Just to highlight, you've all had the paper, but some of the specifics from the health and care improvement groups. I was going to ask if any of the chairs wanted to update, but no one else here today. Julie's been to a couple now, but a bit unfair to bring her in on community. Oh, Joe.
No, it's fine.
So, Joe, sorry. I looked around the table and I couldn't see you. Sorry, Joe. Sorry, Joe. In terms of the Children's Board, you'll all be well aware of the work on the neurodiversity pathway that's been to the board, and also the HCG is keenly developing an action plan for improving health and development in early years. The community group continues to refine and focus its priorities. We've noticed a gap in terms of our supporting infrastructure in terms of coordination of effort related to long-term conditions. So we are addressing that and bringing a group together to enhance our citizens' focus on long-term conditions. Maybe Joe will want to talk about mental health, but I was going to suggest that the group has successfully signed off the inpatient quality transformation programme and has also developed an action plan to deliver the mental health strategy. And the acute group has really now helpfully focusing itself on the longer-term transformation programmes, such as Healthy West and implementation of further implementation of stroke and the impact specialist services. So just to give a flavour of the things going through those groups at the moment, each of the health and care improvement groups has a risk register. We've summarised the risks in the paper, and appropriately they feed through into our system risk register. So really just to note the progress of those groups, Chair.
Okay, thanks, Dave. Question for committee chairs really as to how cited are you on the work in the HSIGs, where relevant? Is that coming through into committee and obviously coming into board where it needs to be escalated into the board? Helen.
I think we've probably got work to do. I had a helpful meeting with Rosie and Dave, which I was going to mention in my update, that we're looking at the terms of reference for outcomes, quality, performance, focused on assurance of governance within the organisation. So I think that will form part of taking updates from HSIGs that are relevant, and also the performance and delivery group that has been sort of set up. So I'd say we weren't there before, but I think the conversations we've had have set us up well for going forward.
So I think you do need to be cited on the work of the HSIGs, and then there needs to be a process of escalation into committee when it needs to run through that governance process. Because not everything will. Lots of things might be operational that don't need to feed in through the process, but some will. And I don't think there's a black and white description of that, but I think we need to make sure that relationship is there with the conversation. Dave? Okay. Sorry.
So I'd agree with Ellen that we need to continue to finesse it. If I think of some of those key areas that I've just highlighted, so the neurodiversity pathway, that has been through committee. So I think we've kind of evolving it, but we could make it slicker as we have done with System Executive Group around performance.
I think my question, so I think there's work to do, but I'm comfortable that we're moving in the right direction, is I think this governance structure's been in place for a couple of years now. Do we feel that it's working effectively? Do we feel that we've got any gaps? Is there consistency across?
So Ellen, I've just drafted. So we've worked on the performance reporting into System Executive. I've shared that with you.
Yeah.
I've also now started to develop that in terms of what are our operational delivery groups, what are our health and care, how they start to evolve. And I think we're going to have a session with the execs and non-execs later in the year, and I think let's bring that together there to look at the breadth of our governance, including some of the quality groups as well. So I think it's a good time to have a reminder and refresh of that, and we're doing that work.
Thanks, Dave. And we have talked about that, and making sure that is an agenda item about how committees are working, how we're linked into the business of the ICB. I got Geeta and then Jaya.
Thank you. I just wanted to come back on the conversation we were having earlier about supporting people better at home and avoiding admission, and thinking that that's a real priority, obviously, of the community HSIG, and how we do bring that through to outcomes, quality and performance, so that we can see that kind of balanced picture. So I think that would be really helpful.
Yeah, great, thank you. Chair.
Do you think that workforce is covered enough at the HSIG level? Is there anything that should be floated to people committee? And if so, how often?
Let me reflect on that. Some better than others, Jay, but some better than others.
Okay, because we don't really have very much direct interaction with HSIGs at all, and it worries me because it's something that we can't see. But equally, if it's not directly relevant, then obviously we want to focus. But if there are elements, then I'd want to know what they would be.
Joe?
Yeah, so Corey, one of the team attends 2, but not all of them, and we attempt to have a triangulation with the People Programme Board, and where issues have been flagged, and obviously we use our non-exec members and members of our People Committee to flag those issues to us. But I think there's a strengthening in that, especially as the HSIGs, become much more sort of active, and we know that our workforce is going to be moving around rather than new elements coming
and
through.
I think that will be a useful conversation in the away day, won't it, about how that's joined up together. Deb?
At the risk of providing a slightly different viewpoint, I just think it's really important. So when we looked at the transformation work for the ASD programme, one of the things that happened was there were 14 different groups in the end, and they're still going, that they needed to go through to get assurance. And it's just one of those things that we just need to hold ourselves about, which is that, so as we're talking in the transformation space around how do we deliver this H2 work so that in service of the Healthier Together 2040. How are we going to be as efficient as possible in delivering impact in transformational work and change and improvement when clinicians talk about spending all their time having to traipse their project round to many different meetings? So it's just a kind of, we just need to be a little bit cautious about the sensitivity to I need to understand everything, and I'm just how we do that.
I don't think it's different view, and I think that would be really useful for our conversation about what needs heavy governance and what needs lighter touch.
And where we delegate decision making and governance.
I mean, it just, I had in my head, the news coverage yesterday on Grenfell and about the relaxation of governance and the impact that had. Now, this is not the same, but just having the conversation to make sure that you're really clear on if you're reducing the number of hurdles, why are you doing it, for what purpose, and what's the unintended consequences? Shane?
And we will explore that as part of our development. But I think it's really important that there are delivery vehicles and then there are governance vehicles. And not every delivery vehicle has to be governed.
No, absolutely.
Okay? I think that's really important. So the health and care improvement groups are delivery vehicles. And that's really important. But not everything that goes in that delivery vehicle has to find its way so that every item is governed by a committee.
No, you can't do your job.
You can't do your job. So if we're going to tie ourselves up in everything we choose to do as exec and system exec is governed by a committee, every decision we make.
And they'd heard about the concerns around the risks of the forecast, but also encouragingly quite a lot of positive activity. We heard about the agency work, which is positive. But it's probably that there's kind of an element of whack-a-mole, because conscious that there is pressure around bank, in a way kind of counting that, but it's good to see that it's being gripped, and we heard quite a lot, particularly about the grip and control being exercised over drug expenditure, measures being put in place around medical devices as these are starting to become an area of increasing exposure, and also starting to see some benefits from focusing with greater rigour on non-pay. So lots of good activity, but it's still a significant challenge. We still have the 40 million as we've talked about. Also, encouragingly, evidence of strong partnership working, particularly among the chief nurses and among the chief medical officers as well, which was encouraging to see. So I don't know if there's anything you're going to pick up around the national funding position. I'll leave that kind of in your hands, so that I can't recall whether that was for public or private consultants. I'll pass it to you.
So shall I just pull out a few key messages out of the finance reports? You've got in the pack both the ICB financial report and then more detail on the savings for the ICB, and then also the system finance report. I'm going to particularly focus attention on the system finance report. So if you go to page 175 of Diligent, that's sort of where I'll be starting. So some of those key messages, like we say, the month 4 position, it was a slight improvement from month 3, which is really encouraging. And I think it is starting to see the impact of some of the work that's been going on with the chief nurses and others in terms of that bank position. So we can see from the report there that in terms of agency, the savings are sort of delivering 116% of what they expected to. So really good progress. And it is that bit about now getting on top of bank as well. But it's early days, but we're starting to see that at least flattening out in those trends. So I think people really getting the processes in place. We are working through the forecast outturn change protocol, which basically requires each organisation to sort of do a deep dive. We are then going to be doing some peer review with the 2 acute trusts, because that is where you'll see page 177 shows the issues by organisation. That's where the majority of the issue is. Within the ICB, the significant driver of our position, so it's a small deficit at month 4, which is really driven by a couple of main issues. The phasing of some of the funded care savings, but good progress being made there. There is still some risk outstanding, but good progress. And then the other area is the high-cost drugs and devices. And Joe's been working with the HCPE, I can't remember what it's done, Healthcare Professional Executive, to really get that brought in. And we have got a group now really looking at the devices and getting some more control in around that. I think the other bit that I just wanted to draw to the board's attention is on page 180, we can see the savings delivery by organisation, and I think it's, you know, we spend a lot of time looking at the things that aren't working, but I think we do also need to recognise the significant improvement we've had in AWP's delivery this year. So really pleasing, and I think, you know, what we've got to do is just carry on, and that's why we've got this protocol in place, is to really make sure that we are getting that buy-in from everybody across the system and really driving the delivery of these savings, because otherwise it compromises our ability to make the decisions and improve the services as we want to. So, but I think really good, I think everybody, certainly at Performance and Recovery Board, it feels like there's really strong commitment to continuing to deliver the plan that we signed up to.
Okay, thanks, Sarah. And it is a big challenge for us, but very encouraging. Any questions for John or Sarah before I go to Deb? Alison.
Just a quick one on the electoral recovery funding.
Yeah.
I know that that's part of the issue of where we are at month 4. What's your sense of getting that back on track, if you like? Because that's an important bit of our funding, isn't it? I just wondered how you think the months are going to go, or what we need to do to bring it back on.
So about 2 months ago at Performance and Recovery Board, we had a deep dive with the Chief Operating Officers. They were both confident at that point that there'd been some slippage in appointments, but that we would get back on track. I think they were quite, at that point, they were basically saying they weren't expecting it to be an immediate turnaround, but they were confident. So we were just having this discussion at exec team on Wednesday about the next and basically planning that they come back to not this Performance and Recovery Board next week, but the one after, to really make sure that we're seeing that coming through now.
So there is some confidence. Yes, that's good. That's good news, isn't it? Thank you.
Hugh.
Guess what I'm going to say? Just to note that councils are in a deleterious financial position. Bristol Council's got to make similar additional savings this year to the tune of 22-23 million in order to balance. Next year's looking increasingly difficult, and if we don't work together as a system to try and address these issues and include the financial issues of the system in these kind of readings, then we're going to have less chance of solving the problems that we've got.
Yeah. And I know that's replicated in other local authorities, perhaps not the same scale as you experience it, but it is there, isn't it? Okay, and I think that's, we'll see how that pans out over the next few months. I mean, we need to work together on it, don't we? Any other questions around the finance element before I pass to Deb? Deb?
So just linking on the finance side of things, obviously there's a lot of work in the digital portfolio around the benefits realisation. That's currently off trajectory, but there is a lot of work to try and get that back on trajectory. The two areas that are probably of note for the board was very interested in the NHS app. So there's been quite a lot of work that's been done in the discovery space to understand where our opportunities lie, but also that's identified opportunities potentially in our acutes, because we've started to think about some of the detail about how text messages are created. I won't get into the geeky structure of it, but how we've got opportunities to think differently about how we use those messages, construct them, and therefore what we spend on those to get the information to the general public. And then the other thing just to say is the Connecting Care contract has all been signed now, and that's due to go live. The big change for that was that we would have a training environment that would enable staff and people to be able to see and get demos so that we could help groups of staff to understand the functionality that's available to them. And we've got a new UX lead, so a user experience lead, who has started, whose role is to look at the redesign of the user interface to make sure that it actually starts to deliver more and drive uptake as per our conversation here at the board in terms of the benefits.
Okay, Deb, that's helpful. Any questions for Deb? No? Okay. Primary care, Alison.
Thanks very much. Jeff, 4 key messages for board, no items for escalation. 3 items of really strong assurance at committee. One was around the system and partnership approach to responding to potential collective action, which we have talked about earlier today, but there was a lot of assurance at committee about the approach that's been taken by the leaders, particularly David's executive lead. And also we do note at committee the strong relationships, because when any collective action has gone, which it will do one day, those relationships are what we're left with, and we do see really strong relationships, which both John and Dave have mentioned in the previous meeting today. So good assurance there. Good assurance on the primary care assurance framework, which came to committee, where it's a self-assessment RAG rated on the responsibilities that the ICB has got. It's not about a RAG rating on the quality of the services. It's the way we're approaching it. So we had some really good assurance there. This will be coming to board in October. There were 4 areas of red, as in where the self-assessment, all around dental, which I don't think will be a surprise to board members. But the approach to undertaking the self-assessment was a really good, thorough approach, and the committee were assured by that approach, and the board will see it next month. We had a really good presentation from the training hub, which gave really good assurance around the setup of the hub, the governance around the hub, and the achievements of the hub. We saw some really good work there, including, for example, 100% take-up of newly qualified GPs in the support programme, which not all areas give, and actually we have been attracting newly qualified GPs because of that programme. Committee absolutely supported the training hub, did encourage a formal evaluation of what has worked and what hasn't, and also wanted consideration for it to be opened up to pharmacy, optometry and dentistry, which there was a query about the funding being short term, but I've linked in with Joe, and Joe's on it, Joe Hicks, and so good assurance around the training hub to primary care committee. And then the final area was around the dental commissioning hub, where we know that there's been a risk on our register, and we know we've been concerned about the capacity of the dental commissioning hub, which is across the region, to be able to support us to deliver what we want to. Hopefully, really, I mean, Shane's spent a lot of time on this, as has Dave, and showed some new governance regionally, where I think the oversight is going to be much stronger. So reassured that the leaders here have been really pushing for this, and also that a new oversight framework will actually help us, because that commissioning hub is really important for us to deliver what it needs to, and then we can transform through the dental reform what we need to do. So some good assurance and some reassurance, which is important at committee.
So we've had some reassurance around the hub. Let's hope it pans out, and we will keep asking the questions. I think for us to go to primary care committee and not get representation there to explain what's going on is a break in the chain. And I know you're onto that, Alison, so well done. I know Shane is, and Dave.
For Mark's benefit, we have struggled to get partner representation from NHS England, and it does help.
Okay, I'll turn that back.
Thank you.
Good. Okay. Any questions for Alison, or anything else you want to add, Dave? Okay, thank you. John, audit and risk?
Thanks, Jeff. The AGM is coming up as time. So the meeting in June, the committee approved the annual accounts, the report and the various supporting statutory submissions, utilising the delegations given by the board at the meeting in May. We had a really good counter fraud return, and we had substantial assurance in the internal audit annual report, but down a little on the previous year, a little closer to the bar in terms of the annual report. So we will make sustained effort to retain the current position, and that will be my message to the audit committee at the meeting next week. But nothing else to add at this stage.
Okay, thank you, John. Any comments or questions for John? I'm conscious we've run a little bit over time, and we are heading for the AGM at 6 o'clock, but I know members of the public have waited patiently. So if you have got any questions, I'm happy to take them. If we can't answer them now, we will give you a written response. But fire away if you've got one.
So I was looking for an update on the future of the patient transport contracts on the NSSG.
Okay, so I'll pass to Shane and to Sarah. We can only say so much at the moment because of the contract situations, but Shane, whether you want to start it off or Sarah?
Yeah, I can just say, and I'm sure everyone understands, and you understand explicitly because you're employees, the contract unfortunately did collapse last week, and we are working really hard to try and get the contract back. a new form of how do we provide safe services to our patients and get, as well as employment. But Sarah, do you want to explain where we are and what we're doing?
Yeah.
As much as we can
Of
within the
course.
contract.
So for board members, SVL informed us on Tuesday, the 27th of August, that they were ceasing to provide services. What we've done, with a lot of support from across a lot of staff across the health and care system, is put in place an interim arrangement, sort of patching things together to make sure that patients are able to get to their appointments. We are just working through, so that's sort of meeting our immediate requirements, and then we're working through, we will have to put in place some sort of medium-term provision while we go back out for a longer-term solution. So we're just working that through and expect to be able to make those decisions over the next couple of months. We are obviously in the midst of getting advice on that.
So can I say, it might not be a great consolation for you at the moment because there's a degree of uncertainty. However, we are talking about it all the time. For board members, you may have seen it play out in the media about the collapse of the contract. For board members' reassurance, this went through a rigorous process in the Finance Committee in awarding contracts. But as Sarah said, we will now need to revisit that quite quickly. But I can't give you any more definitive position at the moment. Thank you for asking the question because it's a really important one. And it's an important one for particularly the people of Bristol and beyond, actually, and for yourselves as well. So yeah, thank you. If we can answer it, we will.
Yeah, no, I was just going to say, can we make sure though that the due diligence for the next provider is like taken a little bit more seriously, because there's been a lot of people left without jobs or anything because of this. I'll put it as it is, cock up.
No, I honestly, I understand how you must be feeling sat there at the moment, but I sat in that finance committee and I know what rigour it went through in awarding the contracts. Now, it's not satisfactory, is it?
No, you've been left with no wages, no nothing.
No, and I understand that. However, we are on it and we will make sure we can do whatever we can do. I can't give you much more than that at this stage, probably, Sarah, can I?
Well, all I, what I will say is, so we went through the procurement process. The due diligence was done in June 23. That's when we awarded this contract. But what we will be doing is doing a full lessons sort of learn to really try and see what we can do in terms of strengthening that due diligence process to see if there's anything further we could have done. So I give you that assurance, we will be doing that.
And as swiftly as we can move on this, we will. Because we can't leave the position untenable where we have to contract out on the very short term. So we are onto it, Shane, aren't we?
Correct.
Any other questions from anybody? Okay, can I thank everyone for their time today? It's been a long afternoon. We've crammed an awful lot in. We've got a break now until 6 o'clock. For those who are staying, I would appreciate that you do. For board members who are staying, I think we got food, haven't we,